Good morning, everybody. I want to thank the diehards who have used all your CMN time to hang out until Tuesday, or you're on some sort of governance thing and you're stuck here anyway. So thank you to the diehards who are here. My name is Gage Parr. I am from George Washington University Hospital in DC, and we're going to talk about you would like to give us anesthesia where, aka Nora. So let's just go to this. Come on. Sorry, I'll go this way. All right, that's me. I don't think this is a relevant disclosure, but I do some expert witnessing stuff for North Gage Healthcare Advisors. I'd also like to say that there's a lot of products shown in this slideshow, and they are in no way meant to be an endorsement. It's just sort of what's available to people to buy. So the learning objectives for this, we're going to learn about the physics of MRI and bring you back to your physics course in high school or college with very little math. Learn about and understand the safety issues that are involved in working in an MRI environment. Learn about the anesthesia equipment available in the MRI environment. Learn about why safety interventions and checklists are very important to put in place in this environment, and learn about the steps and roles and that anesthesia should be involved in when planning an operative MRI suite. So, MRI basics. So at its simplest level, the MRI is just basically a giant electromagnet. Its components are a strong electromagnetic field, radio waves, and computer analysis. And use of these three components and a lot of math gives you really nice images. So just a quick discussion of electromagnetic strength. So the Earth's magnetic field is about half a Gauss. So the magnetic field produced by a magnet in a 1.5 Tesla MRI machine is 15,000 Gauss, meaning that a 1.5 T scanner the magnetic field is 30,000 times stronger than that produced by the Earth. And then so a 3T MRI machine, so the nice machine that gives you really good pictures, that's 60,000 times stronger than the Earth. So to put things in perspective, a 1.5 Tesla MRI machine is 3,000, the magnet of that is 3,000 times stronger than your refrigerator magnets. So the magnet is always on, and that is like, if you're going to remember anything else about working around an MRI machine, just remember that the magnet is always on. And that is the reason for most, if not all, the safety issues you have to think about with MRI. So I'm going to play this little video, which...
Here's an example of the missile effect showing the magnet of the MRI system attracting a pair of metallic scissors.
The scissors were attached to a strong string and then dangled in front of the scanner. Notice the initial position of the scissors positioned about 8 feet from the MRI system. As the scissors are moved closer, they are quickly and forcefully attracted by the magnetic field. Now carefully watch the scissors as they are brought closer to the powerful magnetic field. Notice that at a certain distance, they are quickly attracted by the magnet. Now just imagine what would happen if a string was not attached to these sharp scissors and they were free to move, as you see in this video footage. Look how quickly the scissors impact this ball made from foam rubber.
This clearly illustrates the potential danger of bringing magnetic objects into the MRI environment.
So, yeah.
Here's an example.
Next. So the MRI can be a super dangerous place, and it remains a super dangerous place. Just earlier this year, there was a man, I think on Long Island, who walked into an MRI room, and he was wearing a heavy metallic chain around his neck, and that chain got sucked into the magnet, and he was choked to death. A couple years ago, patient was on an ICU bed. The ICU bed was brought into the scan room. The bed was sucked into the machine, the patient was thrown from the machine, and the nurse was pinned between the bed and the scanner. In 2023, there was also a guy in Brazil who was put into the scanner. He had a concealed weapon on him. The concealed weapon was sucked into the scanner. It went off and killed him. So sort of indirect MRI death, I guess. And then in 2001, 2018, and 2021, there were metal O2 tanks that were brought into the scan room, and those people were impaled by the tanks when the tanks came too close to the scanner. So when your MRI tech is being very anal retentive about making sure that you don't have any metal on you, this is why. They're not just being anal retentive to be anal retentive. Here's a machine that they were hopefully decommissioning, and just another example of the force of a scanner. And I'm going to assume, based on the age of that controls, that's an older, less powerful machine. So let's talk about Gauss lines. When you go into a scan room, there will be lines either painted or the flooring itself will be a line, and it's to show you the force of the magnet at a certain distance from the scanner. So you can see in this, we have a 5 Gauss line and a 50 Gauss line. And then there's the trolley that goes in and out of the scanner. MRI safety zones. So there are 4 zones when you're talking about MRI. Zone 1 is the general public. So say that's your hospital lobby, or if it's a independent radiology center, the lobby of that center. Zone 2 is going to be where patients are screened and prepped, so your MRI waiting room, maybe the locker room where they're going to change out of their street clothes into a gown. Zone 3 is for screened MRI patients and staff only, and that's also the control room. In an MRI OR, if the doors that divide the OR from the scanner are closed, the OR is then zone 3. And then zone 4 is the scan room where screen patients are undergoing scan, and if you have an MRI OR, if those doors are now open, now your OR is also in zone 4. So then we talk about things that are MRI compatible or not compatible, and you'll see this is the sign actually from our MRI suite. So things that are generally not MRI compatible are implanted pacemakers or defibrillators. Some of them, the manufacturers are moving to make them compatible, but they're not all there yet, so you have to check. Cochlear implants, ocular foreign bodies, say your patient was a welder or worked in metal work, and if they have a little piece of metal still stuck in their eye, that may be a problem. Shrapnel or bullet fragments, brain aneurysm clips, neural stimulators, and any implanted device that's not compatible with MRI. So you've always got to ask, is this device compatible or not? So what happens if this happens? How do you get whatever gets sucked into the machine off of the machine? And you have to do what's called a quench. So quench is a rapid release of the liquid helium that is used as a coolant for this large electromagnet that obviously generates a lot of heat. If you quench a magnet, you're going to have a couple things happen. So it's liquid helium, it's rapidly released, and you may have a hypoxic environment as that helium is released. There can be sudden changes in atmospheric pressure and a rapid drop in temperature in the area. So this is a video of a quench. And notice that they're way back from this. But there's all that liquid helium being released. And the button on the left should be in every MRI control room. That is the quench button. If you hit that button, that will cause a quench to occur, and notice how it's locked and has do not touch, and probably looks akin to a missile launch device, because you really don't want to touch that unless you have to. All right, so how do we avoid disaster in the MRI suite? So if you look at packaging, it will often have one of these three symbols on it. So the one on the top is MRI safe, and there's no known hazards of this device in the MRI environment. Something like a plastic catheter or something, or a Foley with no metal in it at all. MRI conditional is something that's been demonstrated to pose no hazards in a specific MRI environment with specific conditions of use. So for example, your endotracheal tubes, mostly PVC, but the little spring that runs into the cuff, the little spring in the pilot balloon, that's usually metallic, can cause a problem. So if you have a patient who is intubated in the MRI scanner, you want to tape that down to the tube or the circuit so it's not flopping around. Probably not going to get sucked into the machine, but also it may mess up the signals. And then MRI unsafe is anything that's known to pose hazards in an environment. So you want to check the labels on everything. If there's a no label, assume it's not safe. And then if in doubt, check with your MRI tech. And they have a little ferromagnetic scanner that they can run over the device and see if it is metallic or not, and could potentially cause a problem. So there are MRI conditional anesthesia machines. Right now, the major one on the market is Draeger. GE is coming out with a new one. They haven't had one on the market for a while. These are safe in areas up to 300 Gauss. They'll have a built-in Gauss meter. The Draeger one here, I don't know. Oop, we'll go back. There's little lights on the top next to where it says Draeger and Fabius MRI, and those will get yellow or red depending on how close you get to the scanner. There are MRI conditional monitors. They have an audible alarm if they get too close to the magnet. They have a pneumatic blood pressure cuff. And then Bluetooth connectivity for the EKG, the pulse ox, and then invasive monitoring lines are possible, and they're wired to the monitoring, and the gas sampling line goes into that with a tube. These may or may not work depending on your ADR and the manufacturer. They may or may not work. But see, you can keep also in mind, this is still MRI conditional, even though it's made for an MRI environment. So you'll have this a certain distance away from the patient in the scanner, and then you'll have a remote monitor in the control room so that you can sit in the control room and monitor the patient. And then you have to, they're different channels. You have to make sure things are on the correct channel. MRI conditional carts, as much as possible, everything that you put in here should be MRI safe or conditional. You're going to have some unavoidable stuff like needles, the fluid warmer if you're using one. We talked about the spring on the valve to inflate the ET tube. You know, if you're having an OR and you put a Pyxis in there, it's got to be as far away from the scanner as possible, and hopefully it's aluminum on the caps, but you never know. Your iStat, anything else you're using if you're in an MRI room. And then these are MRI compatible pumps or conditional pumps. Once again, these are radio controlled, so you can have the pump in the scan room with the patient and then a remote outside in the control room so that you can change the infusion rate, that sort of thing. So even MRI conditional equipment can be pulled into the scanner. Just a couple of things that are supposedly MRI conditional but got too close to the scanner and got sucked in. We have other OR equipment. This is our MRI OR, and you can see, I mean, we're just using regular trays, and these are all metallic. So all of this has got to be cleared out far enough away so that when these big doors open to the scan room, nothing is going to get pulled into the scanner. So what do? We have a very specific checklist to make sure that everything is ready to go. Even changing out the EKG pads to MRI conditional EKG pads, making sure that the monitor has been switched over, because what we decided to do for us is use our standard GE monitor during the surgery and then switch everything over before the scan as much as possible. Just made life simpler and worked better with the EMR. You've got to take the Bovie pad off, make sure that all clips and everything are out of the way. Needles, I worked in a very early operative MRI when I was a resident, and the surgeons were literally standing in a slot in the bore, and they lost a needle, and they were all like looking around on the inside of the magnet to see if they could see it. Fortunately, we've moved away from that. So other things you need to want to check. So you're usually going to have a separate vent in the scan room if the patient is still intubated. So you need an extra long circuit, one, to get in, make sure there's enough room and length for the patient in the scanner, and two, that transfer point from when you're taking the patient from the OR into the scan room. You're going to have a little bit of apneic time, but you're going to want to minimize that as much as possible. Make sure your monitor is on and ready to go. That you're using your EDR, that's your anesthesia records is up already, or you're just going to paper chart. That there is an ambu bag present. Remember, no two tank should not go in the scan room, so you may have to ventilate with room air for a little bit if you need to. All ferrous metallic objects are out of range. We talked about taping the pilot line to the ET tube. And then there should be supplemental oxygen in the room for providers in case there's an emergency quench. And then you need to know who's going to do what, have very specific roles of who does what when transferring the patient, and what we're going to do if there's an emergency. When planning a perioperative MRI suite, you need to have the anesthesia department involved from the beginning. So you need to have an MRI safety officer. You need to have a department member who looks at the plans and makes sure it's going to work from an anesthesia standpoint. They have to work with the hospital on the OR layout. They have to work with the hospital on the proper equipment purchasing. There's got to be a liaison with the operative MRI team. We had a group of consultants that came in and worked with us on building this suite, and I worked heavily with those consultants. You got to work with the equipment vendors on staff education, because a lot of this equipment is a little finicky. It's a little different than what we're used to, and there's got to be staff education. You have to work with the hospital education department to make sure that the hospital staff, the nursing, the surgery techs, everyone else is up to speed on MRI, that they've passed the tests that they need to do to work in that environment. Get your anesthesia techs involved early. This is new equipment for them and a new way of thinking for them. And then we started with a small team of people to work in this environment of attendings, residents. We had an anesthesia tech, and as people became comfortable with it, we expanded that out. Have readily available QA, frequently asked questions information for staff. We keep ours on a central repository on an app that they can pull up and look at any time. And then you're going to have periodic educational updates for staff, especially when you, in an educational or a training center, when you get a new set of residents on board or you have new staff come on board. And then just real quick, similarities between MRI and CT. So both in MRI and CT, you're going to be in the control room during the scan. In the MRI, you can be in the room during the scan, but you open the door, it's going to mess up the scan, and they may have to reset. In the CT scan, you want to be in the control room just because you don't want to get irradiated, but you can go in wearing PPE. The hazard in the MRI is magnetic forces, obviously. The hazard in CT is radiation. Scan times are long for MRI, short for CT, and special equipment, you need all the MRI compatible conditional stuff, and for CT scan, you need lead. and just a final shot. So thanks very much. I am going to pass it along to Judith Hanley, who is going to talk to you about endoscopy.
And I told you I was kind of the comic relief. Can y'all hear me? Okay. If I start to yell too loud, somebody tell me. And if I start to go too fast, somebody put up the slow down sign. When I did a speech class in high school, my best friend sat in the back and would do that for me. So I'm Judy Hanley, and I'm an adjunct professor, associate professor at the Medical College of Georgia, Wellstar MCG Health. We've changed names a couple times. And what's so funny about me doing NORA is that when I was a resident, I trained at UT Southwestern. And if you'd have asked everybody in my class who is the least likely to go into NORA, to like NORA, and you can't vote for yourself, I would have won hands down. But NORA has, as we all know, has grown. I like to know who the audience is. How many people are here because they're the NORA director? How many people are here because they've been tasked or they do NORA and they don't really love NORA? How many people really feel like GI does not get what we do and it says it's just an EGD? Okay, y'all are my tribe, and I also am going to ask some questions and some interaction. I'm going to try to give you some pearls I've learned. I took over in 2022 to 2024 as the director of our Advanced Endoscopy Center and did not ask enough questions prior to signing on that dotted line. Which is the forward button, Gage?
Oh, I was just clicking there.
Perfect. Wait. There we go.
Yeah,
Got
just
it.
go on the-
Got it. Operator. Okay, quick, just some learning objectives. Always good to know what we're learning. Kind of review the requirements and limitations of anesthesia in NORA settings. Specifically, I'm going to talk about GI and in interventional pulmonology, identify patient and provider safety issues that can arise, and discuss kind of the importance of us being involved in the planning from the very beginning settings. And I actually have a real life adventure to give you a little input on, and identify some specialized equipment that we need to often have in NORA settings. As we all know, and there's been lots of articles in the preceding last 5 to 10 years, that NORA just keeps growing. I don't know how it is in your site. How many of y'all ever have a given day that NORA is literally counting all outside of OR, whether it be GI, cath lab, 50% of your total cases? Yeah. Specifically in GI, because we have a really busy, our C-suite decided that this was a good cash cow, so we run 4 GI locations on a given day. And, ideally they want us to do 12 cases per room on the regular rooms and 7 in the advanced room. So that sometimes can be anywhere from 40 to 60% of our total adult OR volume, which is really interesting when you look at that. And we'll talk about our distance in a minute too. But it keeps growing. And then, of course, there's always the complexity of the patients that we're being asked to do, because a lot of times, even in GI, they want to do a stent or something that might have, 15, 20 years ago would have been an open procedure, but they're too sick. How many love the line? Well, they're too sick to go to the main OR, so y'all can just do. Don't we all love that? I mean, it's like, wait a minute. I mean, then my GI guys are really fun on that. Like, if we say no to a case because, or that it needs to go to the main OR, maybe they'll say, well, can we do it under moderate with just the nurses? Yeah, y'all are allowed to laugh on that. So we put in a guideline, which is, we'll talk about why guidelines and us being the leaders are important. We said, yeah, no, if they're too sick for us, they're too sick for you. So some challenges in NORA is having the equipment and supplies. A lot of times, and I've been at places it's gotten a little bit better, that the outside remote sites get the old equipment, right? We get the stuff that doesn't want to be in the main OR, right? Okay, and so that's always fun whenever, true story, at one of the hospitals I've been, it was a Draeger shop. We had Draeger in the main OR. I've been at both in my career. I've been doing this for about 20 years now, and the CT machine was an old Estiva 3000. All right, so now you have a resident who doesn't even know what a GE machine is. So you get the equipment that you're not familiar with. So having mechanisms to make sure you have orientation important. Appropriate monitoring devices. Sometimes you get the oldest monitoring. Support staff. You want to make sure you have really good support staff. And that includes, if you're lucky, and the Advanced Endoscopy Center at MCG, we just got lucky in the last year, and they decided to finally give a dedicated anesthesia tech. Now, before you guys go, wow, we're great. She's actually a young lady who's being trained on the job, but we got lucky because she's incredibly motivated and she wants to learn to do her job well. So, she's only in that building, which is amazing. But then you have patient-related issues. Like I said, they're too sick for the main OR. They're too sick for this. We have to do it here. And then we're doing more. How many of y'all are doing more and more cases out of OR after hours and as emergencies? Yeah, it's interesting. And so, and like I was saying, our building is a little bit farther away, which presents an issue on after OR, after normal time, because we don't have the staffing there from even the support staff. And there's, like I said, the increasing percentage of emergency cases. Now, when you're talking about building an out of OR, so I'm on the Equipment and Facilities Committee and have found my way through times in my career to being part of the, and I've seen it go well when anesthesia got involved really early on. The Cancer Center at the University of Oklahoma, really fortunate that we got involved before stuff even went up on the wall, before the building started. So we were involved in where med lines went ergodynamically, but we had 2 proton vaults. And so we asked early on, are you going to have us do anesthesia in more than 1 proton? You're going to have us do anesthesia in more than proton? And I documented every time I got asked that question. So we put the first proton in and we're doing anesthesia. Kid you not, within the first month, I get the email, hey, Dr. Hanley, would we, if we had somebody who donated money and we had another proton, can we do anesthesia in that building? I mean, in that other vault? Nope, we didn't have the med lines. So being involved from the very beginning is incredibly important. Okay, this is a non-attribution room. That means I know it's going on the line, but my hospital administrators won't be reading this or seeing this. So Columbia County Hospital is a new hospital that my Wellstar Hospital system is building. It's in a different part of town. They want to draw a little bit different clientele, whatever it is. True story. That building is going to be opening in August. We're in October. There are ceilings. There are sheetrock. It's already up. They finally have now gotten anesthesia really involved. We got sent a spreadsheet with a list of anesthesia equipment and got asked the question of, and told, here's what you're going to have. Well, I got asked specifically for the GI. And so they've decided, so we have 2 GI rooms, 2 hybrid rooms, and an MRI, and we're going to be able to cover all of them. Care to guess how many anesthesia machines they gave us to cover all those areas? 1, the MRI compatible machine. Okay, so what that means is that if we move that around and break it, now we can't do MRIs. So we're in the discussion of that. But being involved from the very beginning or as early as possible really does help, because they don't think like, the engineers and architects don't think like us, okay? We were walking over here, true story, we were walking over here, ran into a young lady who practices in Hawaii, and we were talking about Nora, and she says, GI. They wanted them to start doing GI, and they're only doing 1 room at a time, which is fine. But it's this little closet, she said, and the first closet they gave them, and she called it a closet, was so small that the way their scopes were, they didn't have the dual scope system. So in order, if they did an EGD first, they literally had to pull the patient out, turn them around out in the hall, and push them back in. Okay, how many of y'all think that's a great idea? Raise your hand. You know, especially, I don't think it's a great idea, Peter. Sorry, I don't. It's a challenge, and we all deal with the challenges. You know, and then of course their O2 lines and stuff weren't long enough, so they had to, you know, and people don't think about these things. All of y'all are shaking your head, but you can see how if we're not involved from the beginning, how it can really happen. And so and then whenever they refurbish, so at our hospital, the old dental school is what our GI suite is. So the good part about that is we do have a couple of advanced rooms that are truly were set up for oral surgery surgeons, which is great. But then they put in all their GI stuff. So our advanced room, legitimately, if we ever get them to give us Pyxis or Omnicells, I'm not sure where they're going to put it, because their stuff is hardwired in for all their fluoro. And that's the other thing we hear a great deal is, oh, we have to do it in our building no matter how sick the patient is, because the fluoro in the operating room isn't as good. My answer is always, lack of the ability for OR to handle this is not my reason to change my safety line. Repeat after me. Lack of something else, you don't make a lot of friends, but who are our biggest friends? Our patients, right? Our patients, patient safety. So how do we mitigate this? Well, the other thing I'll say is that whenever you start it's not even just equipment planning, it's also planning patient planning. So again, so think about from here to the other side of the convention center. That's how far our endoscopy suite, IP suite is from HELP. I had a really young, fit resident texted him and said, come over as fast as you can. Still took him 4 minutes to get to me. Took me 6 minutes because I'm a little older. So, I live by the rule of threes. 3 minutes, or 3 weeks for food, 3 weeks without water, 3 minutes without oxygen. So we had to really, and when I took over as the director, here's the first question I didn't ask. So pearls for anyone taking over as director. Find out the lay of the land first. I did not realize that we had 125 to 150 patients a week coming through our center. Nobody was pre-oping those patients. How many of y'all think that's awesome? So I was having patients show up with EFs of 15%, but they did their colon prep. So I have to do it. So no, so after many months of looking at the charts and coming up with guidelines, that's my first point. Come up with guidelines if you are a distance away, in collaboration with your group of who needs to be in the main and who doesn't, because you want to make sure you're safe. And first thing is making sure that you actually kind of triage out who needs to be, depending upon how close you are. In an ideal world, there's another part of our hospital that would have been way better for us to put the endo suite in, because we were would have been right across from the main OR. But I wasn't part of that plan. So recently, what am I doing? Sorry, there we go. In 2022, Emily Methencool, who is the chairman of the Committee on Patient Safety and Education now, and a colleague wrote an ASA monitor about what's next in patient safety in non-OR anesthesia, and really teamwork really does matter. How many of y'all at y'all's facility kind of have a smaller team that just go to GI or outside of it? I know that at the University of Minnesota, Dr. Mike Wall, who's their chair, came up with what he calls the RAT team. And that sounds kind of bad. And they have little rats. That's the remote anesthesia team, and they do a lot of their non-OR. And there's something to be said for that, because you either, you figure out a way to kind of approach non-OR, which I'll take that pearl later, or not. But in this article, it really talks about the importance of, and this is a copyrighted ASA, but is on there, care in NORA, as we know, has been increasing, and it's been recognized a couple years ago as a safety issue by the, Anesthesia Patient Safety Foundation, and, as well as communication. And many cases in NORA, are performed under sedation anesthesia, or analgesia, sedation. Or how many of y'all have heard, well, it's just a MAC? Everybody, I mean, same problems, different people, different names. But, this led to the misconception that among both proceduralists and even people doing NORA, that it's just a MAC and it's safer. However, MAC doesn't necessarily confer any more safety. As a matter of fact, especially in the GI arena, where we share an airway, because I do both peds and adults. I'm double boarded, and I've been at peds places where they intubate all their EGDs. I've been at a peds hospital where we don't, and adult where we do native airway. But you have to share that airway, and especially how many of y'all are not only doing shared airway with a GI proceduralist, but have GI fellows. It's July. You know what happens in July? They squirt water. Where's the water go? On the cords. So from that standpoint on being safe from the equipment, we always make sure our ambu bag already has our pop-off valve on it. So because there was another article recently, actually in the same article as I believe this article in the Anesthesia Patient Safety Foundation newsletter, that basically talked about hypoxia in the GI lab. So just keeping an eye on that. But this is having simulation. We started doing simulations, simulating what would we do if we had a malignant hyperthermia? What would we do if we had a code? Really fortunate that we have great support. Good communication. So the other thing that was interesting, you have 4 rooms, and legit, telling the truth, that little dry erase board that's on y'all's right, that dry erase board came up because I'm running around seeing all these patients in all these cases, and I would forget which CRNA was in which room. That is the truth. So those were created so that I would know who was where, and also so the charge nurse or a nurse in a room would know who her provider was. Now that we've gone up to 6 sites, we have both attendings listed and our telephone numbers, or our, we now use Epic. We've gone to Epic, which is great because of the messaging system. Having the right supplies and equipment, because we're far enough away. So if you're having to get all your supplies and everything for your main OR, that can really slow down your turnover if you're having to. But also, the picture that's on your right is, we never plan in our area. We just set the guideline that if it's a patient that needs to have an art line, or is a sick cardiac patient, we have an EF limit now. It's anything less than 25-30 has to go to the main, severe valvular disease. So if it's a case that we're planning on having to put an art line to manage, first of all, that's probably going to our cardiac team. And I made good friends with the chief of cardiac anesthesia when I said, I won't make you come to my building. We'll get you a main OR, because that's where they normally are, right? And there's the comfort and safety of their own, their muscle memory of where their equipment is. But we have to be prepared in case we have something happen, a GI bleed, a patient code. Medications that are close, although in an ideal world for GI, you want to have fast turnover. You'd have an Omnicell or a Pyxis in your own, each anesthetizing location, but we don't, money being what it is. Code cart. Wait, let me go back. I hit twice. So code cart, which is on the other side, having the ability to move stuff. distance. So like I told you and I alluded, literally our building was the old dental building. We are that far away. So the amount of time, think about the amount of time it takes to get help. And I would say also another pearl when you're talking to administrators or C-suite about where you're having to triage anything to go to the main OR or to not be in your suite, is patient safety. And it just becomes a matter of how can we keep patients safe. When we put in some guardrails and some guidelines, we decreased our number of anesthesia stats in that first year by 50%. The GI docs weren't loving me to death, but my fellow colleagues were like, this is good because we feel safe. There's another article by Dr. Chang and Dr. Dudley about, we do timeouts in the OR all the time, right? There's ubiquitous. We have them on the board. So we instituted the timeout system also within GI just to talk about specific GI issues of that particular patient, having staff be familiar with where the code card is whenever you had new staff. So we do actually have a little bit of a checklist now that the circulating and the nurse kind of goes through that talks about those things, but it's specific for our endeavor, for our location. Basic endoscopy room, we'll do EGD, colon, flex cigs. We have to do TIVA because we do not have anesthesia machines in those rooms. So 0. So it's all TIVA. If you have to, which can be daunting, but it's what we do. Challenging cases. So when I first took over anybody care to guess what our BMI limit, because we have a bariatric program. Take a guess of what our BMI limit was. 65. So I have since passed off the directorship, and our EF limit was 20. And we would do pulmonary hypertension up to 70. I would only say no if it was severe. They have now dropped all of those since I took over, which is cool now that I go back over. But we do get some of those patients that do have, sick hearts and sick livers especially. And PEG placements, so we actually put our pegs in with using the high flow machine, which you see a picture of, which is really, really cool. But now that I've started working on our main OR some too and doing some pegs in the main OR. And all of my colleagues are like, wait a minute, you're not intubating? I was like, no, I'm doing it the same way I would do it endo. They're using the same kit. Why would I do it different? Inpatients, how many of y'all, the whole battle about the sick inpatients, inpatients, especially at an academic center, our GI center is supposed to be an outpatient ambulatory, but really it's more of a hybrid. So having the sick inpatients on top of outpatient, the volume that they want for outpatient. So my other adage that I said was, you can get volume or you can get acuity. You cannot get both. And if you have any of y'all have studied econ, you have the supply curve and the demand curve and the supply curve, and there's a sweet spot where we can give some of both, but you cannot have everything you want. Advanced GI cases, we do ERCPs because our floor is better. We do tend to intubate our ERCPs. How many of y'all will LMA or native airway an ERCP? Great. Would love to find out how you do it because it's not something we've ever done a whole lot of. And how many have their interventional pulmonology co-located? If you're far from the OR, that can be really daunting because of their airway concerns. Fortunately, we've developed a really good relationship with our IP docs who we coordinate well. We do not do any jet ventilation in our building, so that's always something to consider because jet ventilation is a whole nother level. Post-anesthesia, having your own post-anesthesia with enough bays and pre. Ours is kind of set up in a circle. So we have pre-op here, you walk through the doors, and then we have the procedure rooms. It's like 2 circle 8s. So I get all my steps every day at GI because you're running around. But my final thing and comment will be, and we'll have time for questions for all of us at the end, is be involved in the planning of it. Be involved in planning the guidelines and the patient selection of who needs to be there. And then this is true in every talk that we should give as anesthesiologists. We're the physician leaders, and we need to be the leaders not only of our own anesthesia team, but also of the care within that unit. Thank you guys for your time. The reason why we're laughing is I can make a 1-hour talk go in 30 minutes, so I thought I was going to be like 5 minutes.
All right, good morning, everyone. My name's Christian Taylor. I'm a pediatric anesthesiologist in Children's Mercy Hospital in Kansas City, and I'm here to talk to you about anesthesia considerations for the cath lab, an electrophysiology lab, and we're sprinkling in a little bit of interventional radiology. All right, quick disclaimer. I'm a pediatric anesthesiologist, so a lot of my talk will be tailored through that prism. So, I'm not going to be able to answer all your questions about a lot of adult advanced techniques in the adult cath lab. So I just want you to keep that in mind. And, on a good side, I took all the pictures on my own, so there's no copyright issues. The downside is that they're with an old iPhone, so I apologize for the quality. Quick background, we do about 1 million cases a year in the U.S. in the cath lab. We do a variety of cases. I'm not going to mention all of them, but both diagnostic and interventional cases. And so in pediatrics, we do a lot of collateral embolizations, atrial septostomies, and valvuloplasties that might not be done as much in the adult world. And then in the EP lab, it is growing. From 2013 to 2019, the percentage of cases that were done according to CMS data, it went up by about 25%. And, it's the usual things, AFib ablation, SVT ablations, medication challenges for diagnosing Brugada syndrome, and then a lot of device placement, whether it be a pacemaker, an ICD, a generator change, or a loop recorder. So many of these cases are done under sedation, and I would say in the adult world primarily. And that may or may not involve an anesthesiologist. But we have to be prepared to take care of these patients and provide the full spectrum of anesthesia services to them. And it really just depends on the patient, the proceduralist, and the institutional factors that are in play. So what cases typically require an anesthesiologist? It's those patients that are unable to lie flat or cooperate with the proceduralist, whether they have anxiety or claustrophobia. Do they have any hemodynamic or respiratory instability that might require advanced airway maneuvers? Patients that have TEE needs during the case typically need a deeper level of sedation with our service. And then, of course, patients that have valvular interventions or advanced device placement where the patient needs to hold still in a precise moment, we're typically involved in. And of course, testing for ICD devices is not a comfortable thing, so we need to keep these patients asleep. And from my perspective, almost all children that are coming to the cath lab or electrophysiology lab require general anesthesia. There are a few exceptions where we do it under a MAC. And most of them are just prolonged cases. They've got cyanotic heart disease and prolonged procedures, and it's just easier to take care of them with general anesthesia and intratracheal intubation. So if I could really oversimplify our anesthetic goals for these patients, is to provide comfort, immobility for the proceduralist, and minimize our anesthetic alterations on their hemodynamics. So what are our perioperative concerns? We have to understand what their underlying cardiac pathology is and the impact of our anesthetic on their physiology. They're frequently complex patients with multi-organ dysfunction, and they're high risk for any procedure. We're using contrast for these patients, so we have to have considerations for their underlying chronic renal dysfunction, in addition to the risks to causing acute kidney injury. And frequently there's max doses of contrast agents, and if they need to have another procedure to follow, you have to understand the time limitations to allow that contrast to wash out. In the pediatric world, patients with congenital heart disease have a much higher risk of having a difficult airway, so we have to keep that in mind. We're frequently giving anticoagulation during these cases, so we have to keep on top of measuring ACTs and redosing and when we need to reverse at the end. Some of these patients need antibiotics, so we have to understand when they need SB prophylaxis. And in our institution, it's generally when a device is left in a patient, we will give pre-procedure antibiotics. We have to understand that certain medicines we give will affect the physiologic parameters that the proceduralist may be trying to measure. So if you're in the EP lab and you give lidocaine or Precedex, you may impact their ability to map that arrhythmia. If you're giving phenylephrine or epinephrine in the cath lab, that's going to impact the measurements for the cath lab physician. So you have to keep in mind that you need to communicate those needs to the proceduralist so they understand the situation as well, and avoid those medicines if possible. You have to keep in mind what FiO2 you're providing the patient. You know, in the cath lab, when we're doing hemodynamic studies, we need to be on room air because we want to recreate the most realistic conditions for that patient when they're at home. Sometimes we need to have backup pacing and defibrillation equipment immediately available, particularly in the EP lab. And then some patients are extremely high risk for the procedure itself or for the anesthetic. So there are a few times where we'll have our cardiac surgeons on standby waiting in the control room in case things go south. And in our institution, we like to combine anesthetic cases if we can for our patients to limit the number of anesthetics for our patients. So we'll start a case at 7 a.m., do a cardiac MRI on a patient, transport them upstairs across the hospital under anesthesia into the cath lab, and then perform a secondary procedure. So there's a lot of transport, scheduling, staffing, and logistical hurdles we have to consider for our patients. There's a lot of things we expect to happen in the OR, and some things we just need to be prepared to deal with if they arise. Very common things are hemodynamic changes during pacing, during our EP cases, device deployment, anytime a balloon's inflated. We're going to have changes into our end-tidal CO2, oxygen sats, or blood pressure. So we have to be ready to deal with that. Our ventilation requirements, we frequently need to have breath holds for an extended amount of time or decrease our tidal volumes to limit movement during a precise catheter placement. And my favorite is the 3D rotational angiography when the fluoro machine is spinning and you have to make sure that it doesn't pull out a vital life support or monitoring line. And of course, the procedure table is constantly moving. The fluoroscopy equipment is constantly rotating in and out of plane. And you have to make sure that that's not impacting the patient or causing any kind of crush injury or pushing the endotracheal tube into a location where you don't want it to be. And those are common, and we have to be vigilant for all of those things. Some unexpected but possible situations are an unanticipated cardiac arrhythmia or acute cardiac dysfunction during a procedure. There can be a vascular injury or perforation, and that can be both at the access site, or it could be a right atrial injury or a pulmonary hemorrhage during a procedure. So you have to be prepared to manage that patient. I have yet to see this, but you know, a pneumothorax is always possible. It's rare that we get neck access for our catheter-based procedures, but it is always possible. Embolic phenomena can occur, whether that be from air or from a thrombus. And of course, device deployment that becomes dislodged or not in a spot it's needed to be can cause immediate and catastrophic conditions for a patient. And you might have to immediately perform cardiac surgery in that room. And you have to be prepared for that, even though it's rare. The most important thing is to have constant communication with your proceduralist. You need to understand what they need. You have to tell them what your needs are during the case, because things change during the course of the procedure. As you're giving medicines and supporting the patient, you might be changing the conditions for the proceduralist. And so understanding what both of you are dealing with is important for you to understand. And of course, when things go south, you need to have a plan for collaboration and crew resource management. It does feel like an island when you're in the cath lab, at least in my institution. We're not right next to all the other ORs, so you have to understand that help is further away. These cath labs tend to be in repurposed sites, so it's like everybody else has said today, they weren't designed around the needs of the anesthesiologists. And again, I already mentioned this, but you know, just having your cardiac surgeons and fellow cardiac anesthesiologists further away does delay things when you really need them. Your life support equipment, whether it be ECMO, a balloon pump, or an ultrasound machine, they take longer to get to your room. And they can't all be available 24/7 right next to the patient. And then your tech support our main tech supply closet is close to the main OR, so it takes a little bit longer for things to get to us. And of course, any radiologic procedure room, you have to deal with radiation hazards, and slips, trips, and falls and boom strikes are common for all of these places. You have to keep in mind that the patient also has risk to getting injured from the fluoro machine, moving equipment, and the endotracheal tube being moved by the equipment. And then these imaging equipment devices need to have special cooling needs. So it's hard, and from a pediatric perspective, it's hard to keep a patient warm or at the appropriate temperature when you can't warm up the room. So you have to think of alternative warming devices for your patient. And then the ergonomics, this is a recurring theme for all of us, but it's not, these rooms are designed around the needs of the proceduralist. So it's difficulty in accessing or getting close to the patient. We have lead and radiation barriers in place, and then cord management issues. But I was going to make a joke that at least we're not in the MRI where we have to deal with ferromagnetic equipment issues, but as Gage showed in her slide, which I don't have to deal with yet, is cardiac interventional MRI suites. So they're on the future for all of us. And here's my quick slide about interventional radiology. We do a lot of these cases. There's 10 million procedures that were done in 2023. It's growing at a compound growth rate of 7%. There's a lot of reasons for this increase in demand, whether it be increasing prevalence of chronic disease, advances in minimally invasive techniques, and technological innovations. But the themes are very similar. You're away from your surgical ORs, you're away from your colleagues, you're on an island. These are very sick patients. You have equipment and space issues to deal with, and of course, radiation. So I just have a few quick slides to show everybody our pictures. This is on the left is our kind of base setup for our cath lab. We have two planes for our fluoro machine, and the pivot point is right under the patient's head where it would be. So no matter what, when they rotate it out, you still have issues with it being by your feet, and you can't really get an ideal standing position. And then on the right is kind of what the typical look is after we've started a case and they only need to use one axis of the fluoroscopy equipment. And as you can see, they pulled out the lateral fluoro piece of equipment, but it's conveniently out of the way of the proceduralist, but it's in the way of our anesthesia machine. So you have to kind of navigate, and you have about 18 inches of room to get close to the patient. Radiation barriers, this just shows in our cath lab and EP rooms, the types that we use. We have one that's a large kind of door with a leaded glass window, and it works great, but it's hard for having a conversation with the cath lab proceduralist during the case. And in our EP room, we have a smaller one because they use less fluoroscopy. But regardless, they're both in the way of you and the patient. Some life support equipment issues. So this is a patient, I'm assuming that they were a 1 kilo patient where we were doing a piccolo device, but they've got a large IV pole, multiple infusions. They're critically ill. They need the ICU ventilator because it's better at providing adequate tidal volumes compared to our anesthesia machine. They're on it. There's a nitric tank over there as well. And it's just difficult if you have issues with your patient to get to them. And on the right is the typical look of a patient in our EP lab after we've gotten everything set up. We're under anesthesia and they're about to start the case. But I wanted to show this picture to show how close that they like to get the fluoro equipment to the patient's chest. And as you can see, it's actually below the level of where the endotracheal tube is lifting up the drape. So every time they move, rotate, advance the table, that can cause problems for the patient. And you have to be mindful of that. And we frequently have to say, hey, we're getting too close. So, we can't do a lot of things to improve the ergonomics after it's already been designed and implemented in your hospital, but we did do a few things that seem to help. And for our more straightforward cases where they're not on 12 different infusions, there's no IV pole needed, On the left, we added a extendable boom with an IV pole hanger so that we could hang our IV fluids from it, so we didn't need a separate IV pole to be in the way. And that does make things a little bit easier, and it's kind of an emotional win for us. That way, it hangs right where the ventilator tubing is. And then on the right, this is our cardiac surgical OR. I'm sorry. Where I can't tell you how many times where I've almost tripped over this electrical line that's supplying our IV pole when I walk around from the perfusion pump to the anesthesia area. So we designed to get these little hooks, a simple fix that helped kind of hold the cord up so it could be suspended and come down to our IV pole. And sometimes little fixes like that can make things a lot safer for you. And a quick little blurb to mention our machines have feelings too. This was a brand new IR suite that was constructed about 2 years ago, and within 3 months I went down there to do a case and I noticed that there was a hole in the ceiling. I don't know how it happened or if something was lifted into it. And then 3 months later I went down there again and there's a second hole. So I think there's some growing pains when new equipment is brought in about understanding the hazards that they pose to not only the patient but to their own machines. So just be mindful that this is really expensive equipment and we have to look out for not only the patient but ourselves and the equipment as well. And I think that's the end of my presentation. Hope that was quick enough.
That is great.
And we can just sit down if anybody has questions.
We do have time for a few questions. Thank you guys for coming.
Hi, I'm Vijay Guru from Yale. It seems as if the NORA space would be the best space for AI and ML innovations, especially in terms of pre-op evaluations, making a skeleton pre-op, and we have these really, 15 cases in a room, or having some sort of target-controlled infusions, clinical decision support. Are you seeing, any of those in your spaces?
We aren't at the moment, but my chairman is very interested in AI, so I certainly see that being something that will be entertained.
Yeah, we have not seen any. Well, I will say that there's a lot of stealth technology for our neurosurgeons who are mostly up on that floor, and they have some lovely imaging that I'm sure is AI, but it hasn't filtered off to us.
Yeah, I would say the same thing. I'm still yet to even know what AI is going to do for our specialty, and I missed a really good talk on that. I think it might increase our workload by having a lot more efficient, from a radiology side of things, they can identify more patients and be more efficient on their side that need secondary procedures that require our service. So I think the demand for us will go up, particularly with AI innovations on the radiology side.
Dr. Balani from Minnesota. Is it time for us to work on a robot so that we can maneuver through those small spaces? Because that's something for the future, I think.
I would agree. If they made a boom that had all of the anesthesia stuff, I know that we got one for electricity and hoses and things, but anything that can decrease the amount of times that we need to watch our feet while we're looking up and then we hit our head on a different boom, I would be all for that.
Yeah, I know that some of the anesthesia machine manufacturers have machines that can be boom mounted instead of on the floor, and I think in a space like this, that might be an excellent use of those.
Dr. Handley, I used to work in a hospital that actually, we had as much a volume in endo as you, but everything was on the first floor, so we would tell them then still sometimes to go to the OR, but I don't understand how your hospital created, endo suite out in such remote location.
Because anesthesia wasn't involved in the decision. This is my editorial. I can't say for sure because I was actually not at the university when they made the decision. I was still at Oklahoma and I moved back to my home med school. They just wanted to have the volume, and they didn't have the volume in the main OR because they were in a spendo site that was right outside of the OR, but they could only have 2 rooms. They wanted to maximize that to 6, and that was the only footprint they could find. And nobody really thought about the level of acuity of patients and just assumed that anesthesia would do whoever they brought to them.
But I know that you get some very sick patients because I've seen them that are in the ICU.
They're done. Those patients are generally done in the ICU. I didn't specifically say it. We don't bring ICU patients. Actually, most of the GI procedures that are ICU patients are done at the bedside in the ICU. They're not even brought downstairs.
Okay.
The exception to that would be ERCPs, and then they go to the main.
Okay, thanks. Dr. Taylor, just one question, maybe off the topic. Do you do PAC blocks for pacemaker replacement?
No, we've actually discussed maybe doing a pathway for an enhanced recovery pathway that involves some regional anesthesia for our generators, but we have not done that step yet.
But is there any evidence in pediatric anesthesiology that helps? Because I do obviously those procedures for the adult. I'm not pediatric anesthesiologist, and we don't do PET blocks for that.
Yeah, no, and we have most of the sites. A TAP block probably wouldn't be the ideal block. It would probably be, like you were saying,
Not TAP block, PEC block.
Yes.
PEC 1, PEC 2.
Yes. We have discussed that with our procedural colleagues as maybe adding that, but we have not implemented it yet.
Okay, so there's no clear evidence that, that provides high benefit because in adults, we don't do it.
I think it could help. I'd probably an area we need to look into, but it's been an idea that, a lot of these patients are teenagers where it probably would help their postoperative course.
One final comment to you. At our new hospital, they did listen to us from before, and so now all of the GIs, everything is co-located close enough to where it won't be a problem at the new hospital. That was a lesson learned that's already been applied.
Thank you so much for your talk. And Christian, your images, I'm going to have nightmares. So many elements that are terrifying to me, not only worrying about hitting your head and all the things that, we know about, but then having a tiny baby with 1 million wires connected to it. In my experience, the GI suite is never right next to the OR. So I think that's actually quite common to have it retrofitted for the anesthesiologist in every hospital that I've worked in. Unfortunately, would be nice if they were right next to the OR. Gage, I really appreciated your presentation, but I also wanted to offer just a couple of things that occurred to me while you were talking about it, and the O2 tanks. And thankfully, I haven't had to give MRI anesthesia in a few years, but having had to do it frequently before, having long tubing is like your best friend.
Yeah.
So you can leave everything, including the oxygen tank, and even if the suction is far away, everything outside. Oh, and earplugs. That was the main reason why I didn't like to be in the room with the patient. Super loud. But thank you so much for your talks.
The other way we softened it with GI is we actually were able to work with the OR PMT and get them some OR time, so it wasn't as big of a hassle, and it also streamlined them having the equipment. So we solved it and still maintained safety.
Just want to say, booms are a great idea as long as you're involved in the design, because the idea of moving machines is nice, but if you don't have the proper degrees of freedom,
Right.
and you're kind of stuck in whatever arc
Right.
you move.
And then you wind up in the head strike world too, so, which is another problem.
Thank you all for coming on
Thank you.
Tuesday.
All right, thank you.